A very good evening to all the respected dignitaries, seniors, colleagues, experts on Zoom as well as YouTube Live. Welcome you all on behalf of Maharashtra Academy of Pediatrics for today's unique program, Immunization Dialogue. I, Dr. Neha Singh, MAHA-IP Women's Committee Co-Chairperson and practicing pediatrician from Navi Mumbai, Raigad district, welcome you all for today's program. Friends, vaccine is one of the best disease prevention techniques. Vaccines development intend to protect the individual as well as the community health. Because of this significant contribution from vaccines, the diseases that were once termed as childhood diseases are now called vaccine preventable diseases. So now in today's program, we have a panel discussion and the moderators for today's program is Dr. Lalwani sir. But before that, I want to invite our Maharashtra President, Dr. Ramakant Patil, sir. Over to you, sir.
Thank you, Neha. Warm welcome to guest faculties today, Dr. Arun Wadhwa, sir, from Delhi, and young dynamic vaccinologist, Dr. Sagar Kulkarni from Aurangabad, and past IIP President of Mumbai branch, Honorary Secretary General of CIIP, and VCVIP member of 2014-15, and a financial guru for many of us, Dr. Praveen Mehta, sir. We have got these three guest faculties. We have got an honor today to have Arun Agadwa, sir, again for this immunization dialogue. It is very difficult to get the time of Wadhwa, sir, but since it was a panel discussion and late night at 9:30 p.m., so he with definitely with on cursing and insisting, but he couldn't say no, and he accepted our invitation. Same thing with Dr. Mehta sir and Dr. Sagar Kulkarni. Friends, we have got slight difference this time. Every time we had a lecture for 20 to 25 minutes and then panel discussion. And today's panel discussion will be moderated by my close friend from my alma mater, BJ Medical College, Pune, who happens to be a director and vice principal at Bharati Vidyapit, Pune. And he has got a multifaceted, pages will be 3-4 pages for his introduction. A formal introduction will be done by Neha, but I thank Sanjay to along with Sanjay Marathe and Rajendra Khadke, successfully conducting this immunization dialogue for this will be the 10th session, and it is a big hit. Nearly we have got always every time 100 capacity of Zoom full and another 150 to 200 from YouTube, and that data usually comes to us for MMC credit point. So sole credit goes to all guest faculties and 3 core members of this immunization dialogue, Dr. Sanjay Lalwani, Dr. Sanjay Marathe, and Dr. Rajendra Khadke. And Mehta sir and Sagar, we every time have one guest faculty, but this time we have got an honor to invite you both of you as a guest faculty. And we cannot say guest faculty because we had defined guest faculty who are not from Maharashtra, because this program is for MAHA-IP. So you are the core member of MAHA-IP. So you are honorable faculty for us. So before taking your more time, I hand over the baton to Dr. Neha for formal introduction of. They are all known, but it is as a customarily we'll definitely like to introduce all 4 of them. Over to you, Neha.
Thank you so much, sir, for your blessing. The panel discussion, but our guest of honor is Dr. Arun Wadhwa, sir. He is consultant pediatrician and practicing for last 31 years, visiting consultant at Rainbow Children's Hospital. Sir is member of ACVVIP since 2022-23. Sir has been editor of several textbook chapters and also has penned 11 journal publications. Sir is National Trainer of IIP Vaccinology course and Chief Patron of NGO Eye Care, Clinical Director of Special Olympics Bharat, author of book on Child Care Treasured Moment. He is founder secretary of IIP SDVP, North Zone EV of CMIC Chapter 2021-22, and Sir has been twice Executive Board Member of Delhi IIP.
Thank you.
We welcome you, sir.
Neha, sir has got prowess in multiple facets, writing book to being a clinical director to Special Olympics Bharat and computer chapter also along with vaccinology. Thank you, sir.
Thank you for calling me.
Go to
Thank
you,
you
Neha.
so much.
Yes, sir. Our next panelist is Dr. Sagar Kulkarni, sir. Sir is owner and director of Bhakti Children Hospital, Lakshmi Nagar, Aurangabad, Maharashtra. Sir has been faculty at various national conferences and CMEs. Sir has indexed editor-in-chief and contributory author of Vaccinology Simplified book and contributory author book Adult Immunization in Office Practice. Sir has been past secretary of IIP Aurangabad 2019 to 2020. Dr. Sanjay Lalwani, sir, is Vice Principal, Medical Director, Professor and Head, Department of Pediatrics, Bharati Vidyapeeth Medical College and Hospital, Pune. Sir is West Zone member of IIP ACVIP Committee since 2022, Chairperson of IIP MEC Medical Education Chapter. Sir has received many awards and has been faculty at various conferences. Our next
Praveen Mehta, sir.
Yes. Pallavi, ma'am.
Praveen Mehta, sir.
Our next panelist is Praveen Mehta, sir.
Please go ahead.
Welcome, sir. And Praveen Mehta, sir, is consulting pediatrician with special interest in vaccinology, Jack and Jill Nursing Home at Honorable Pediatrics Hindu Sabha Hospital, member of ACVIP 2014-15, faculty of IAP ASOV Advancing Science of Vaccinology Program, past Honorable Secretary General of National IAP, past President IAP Mumbai Branch. Now I hand over to Dr. Lalwani, sir. He is the moderator for today's panel discussion. Over to you, sir. And viewers, please note today's program has been granted 1 MMC point. So kindly write your central IIP and MMC number in the chat box. Thank you. Sir, kindly unmute yourself.
Good evening, Neha.
Yes, sir. We can hear you.
You can see?
Yes, sir.
Like not yet visible, Lalwani sir.
Slideshow, kindly do it slideshow, sir.
Yeah, I'm just doing it. Okay.
Yes, sir. Yeah.
So I think today we have 4 vaccines which we need to discuss and get the doubts cleared of pediatrician, and all this peculiarity of this vaccine. I hope I'm audible and clear.
Yes, sir. You are audible clearly.
So we are going to discuss 4 vaccines today. That is the MMR, chickenpox, varicella vaccine, varicella zoster, and the measles vaccine. Now, I will take the questions. We start with Dr. Mehta. Sir, these vaccines are used in the UIP and the ACVIP. What is your opinion of the use of these vaccines in the national program versus in an IIP schedule, especially the measles, mumps, and the rubella containing vaccine?
Thank you very much. At the outset, I want to thank the Maharashtra IIP for giving me this opportunity to interact with you all. And now you all know that there is a difference between the measles containing vaccine schedule in the government setup and in the private setup. In the government setup, they give MR vaccine, and in the private sector, we all use MMR vaccine. Now, MR vaccine, as we all know, contains measles and rubella, which is missing the mumps component. And in government setup, they give only two dosage, one at 9 months and one at 18 months. Whereas in private setup, we also give mumps containing vaccine, that is MMR, and we require three doses, one at 9 months, 1.5 years, and one at school going age. Now, the major difference is the government perceives that the mumps burden is not significant, and they find that the cost of the inclusion of mumps antigen is little more expensive, and they are more focused on prevention of rubella syndrome and also the morbidity and mortality of measles. So they have not included that. And because in the private practice we have included the mumps also, there is a third dose. And as we know that the rubella, you require only one antigen to give one dose only to give lifelong protection. Measles also, by and large, one dose is sufficient, but sometimes there can be a primary failure, so we give two doses. Whereas mumps, the immunity wanes, and mumps immunity depends on the time passed since the last vaccination. And because of mumps immunity, we want to provide it for a longer duration. Uh, the mumps vaccine, that is MMR vaccine, is included at 4.5 years also. So we give three dosage, 9 months, 1.5 months, and at school going age. Whereas in government setup, only two dosages are given. These are the basic difference in nutshell.
Yeah, Sagar, do you want to add anything which Dr. Mehta has told?
Yeah, I would like to add one thing. We used to say as ACVIP that the government is not starting rubella vaccination earlier, government is not starting mumps vaccination. In fact, IIP had taken so many proactive steps. But in this sense, let me tell you, UIP was correct at that time because the coverage of measles vaccine was only hardly 60%. And if we start giving vaccine at that coverage, we might end up into shift of the epidemiological age of the disease. So if we give rubella and the coverage only 60%, we might find more CRS cases. So when the government was ensured that yes, the coverage of measles vaccine is 80% and more, then and then only they introduced the rubella vaccine. So in a sense, it was correct. As far as mumps is concerned, government is still not convinced about the mumps mortality, and definitely one day will come and they will understand that mumps is also important vaccine. But at present, it is not a priority. The rest, probably Mehta sir, whatever sir has said is exactly correct and true.
So I think most of the both the faculty have told. So I think the take-home message was when we started the vaccination initially, it was measles standalone. There was a rubella standalone vaccine. In year 2017, they ran a campaign called as an MR campaign, in which irrespective of the measles status, every baby from the age of 9 months to 15 years was given a single shot of an MR vaccines. It was given a single shot of MR vaccines. And subsequently to this, the government started involving the MR vaccine in the UIP. Now, the measles first dose gives you a seroprotection or a conversion of 85%. A giving of two doses gives you a seroconversion near 100%. So rubella, as Dr. Mehta told, one dose is sufficient. Measles, you require two doses actually to see that large number or near 99% seroconvert. And for the mumps, usually you require the three doses which is there. Now, the government has not taken the mumps in the immunization schedule. It is the MMR, measles, mumps, and rubella. I think, Sagar, a next question to you is that what are the Pratik's mother is very anxious for giving the first dose. We always get parents which are quite anxious, and it takes time to counsel them, and they do ask a lot of queries about these vaccines. And the child is going to take the first dose of MMR vaccines. How will you counsel her regarding the adverse reaction following vaccination? How frequently do you see in practice, and are they really worrisome?
Right. So basically, this is all because of a flood of information which is there on Google, and many false claims about linking MMR with autism, linking MMR with diabetes, linking with anaphylaxis, linking it with reaction, linking it with developmental, and all these informations do come on the website. And so there is sometimes anxiousness in the minds of mother. The only thing which I follow is I tell the mother that there are always some risks, but the benefits are more. If at all the mother is still not convinced, I explain it to them the mortality, the morbidity, the complications, and try to explain her that there might be some very few, very rare adverse events, but that is there with each and every vaccine, and there is no need for her to worry about them. So vaccine hesitancy, we have to solve the issue, and there are ways of doing it. That is what is the basic crux of the discussion, definitely. Every time, the more focus is on benefit-risk ratio. So every time in each and every vaccine, the benefits are more, the risk is very less. Even if this is anaphylaxis, the risk is 1 in around 10 lakh doses administered. So it is very rare. And the last thing which I would like to say, how much to divulge to a lay person is in our hand. Only those things which are really significant data-wise, insurance-wise, only those and those things need to be explained. Rest are to be kept for our own self, for our own knowledge. That is very important.
Yeah. So actually, if you see,
Lalwani sir, over to you.
Yeah, as you Sagar has told, the benefits far outweigh the adverse reaction. The adverse reaction are very mild, but if the parents are really worried, you can just sensitize them that measles, you can get a fever or rash maybe a week after and last for a day or two. Mumps, you may get fever, which may be mild often a week after vaccine, and sometimes rarely an aseptic meningitis like picture. And rubella, of course, may give rise to arthritis or arthralgia 1 to 3 weeks after post-vaccination. Now, one more question
I wanted to add that, Dr. Lalwani, here parents are not bothered about the fever and rash or the mumps-like swelling. They hardly take notice of it. Although we tell them it's only, these social media, Google, like Dr. Sagar said, they're worried about autism. And quite a few people still come and say that we don't want the vaccine now, we might take it later. And it's because of that one paper published by Andrew Wakefield in 1983 or 84, it was published. And he said he found the incidence of MMR after that, soon after that, this happened. But after that, obviously, this paper was withdrawn and lots of studies have been done. Millions and millions of children have been followed up, and they found that there is no relationship between autism and MMR. So we have to now convince parents. Some of them do get convinced, but some still say that we don't want it and we will take it later. They are still not sure. They don't want to believe us. So that is the autism is the only problem people have against MMR. All other side effects are hardly any.
Yeah, I think, Arun, there were some incidences, of course, they are not that frequently heard now, that there was measles given in the campaign mode or given in the peripheral outlets of government.
The staphylococcal syndrome.
And there were some deaths reported, especially in Uttar Pradesh and Bihar. Of course, it's long time back.
But that was just a multi-dose vial with measles. No, what I'm saying is in our actual practice, the parents are worried only about autism. Rest all they don't worry.
Yeah, but if there is some deaths due to measles vaccination, which you told, which may be due to, that's why once you reconstitute the vaccine, preferably you have to use within a specified period. And there are few cases of toxic shock syndrome which have occurred, and that has caused to a fatality. And of course, that can have a negative impact on the national immunization drive. Sagar, in one of the villages in the outskirts of Pune, there has been an outbreak of measles, and we did see a lot of outbreak of measles post-COVID. Now, if you look at the resurgence of measles which has taken place in India, there are behind the measles actually incidents which has really propped up post-COVID. And in Maharashtra like state, it was the urban slum population where we had a higher incidence of measles, and Mumbai, Pune, Nasik were the three urban areas where we have had a high degree of measles. And the government did go in a campaign mode, weighing that even the babies who are as small as 6 months can be given measles vaccination, just so that to prevent them from getting this measles. So you have an outbreak of measles disease. So how can you protect all the children less than 5 years of age? Sagar.
Sir, I think Sagar sir is not in the room.
Yeah, Dr. Mehta sir.
Yes, I can take up this question.
Sure.
Now, see, in Bombay, we have witnessed a huge outbreak of measles, and most of the cases which had occurred were not given measles vaccine at all, particularly during the corona period. During corona period, there were many missed vaccination, and measles was one of them. And as Dr. Lalwani rightly pointed out, that it is more into the urban slum of the large cities where the problem has occurred. And now the way to tackle that is to give measles vaccination on a large scale, isolate the child who has got the measles, and during that phase of active campaign mode, we can even give vaccination for children who have completed 6 months right up to the age of 5 years who have not been given measles vaccine. And if you give it below the age of 9 months, then don't count this dose which has been given below 9 months, and continue with the remaining doses as if the first dose was not given at all, if it was given below 9 months.
I think Praveen has specified, sir, that it can be given in up to as early as 6 months of age, but do not count it. And Arun, you want to add anything?
No, same that, we have to vaccinate all of them. And all these children, whether they've been vaccinated or not, they should get the dose. Anybody above 6 months should take. And as like he said, 6 to 9 months, if anybody gets the vaccine, do not count it. Give 3 more doses if we are giving in a private setup, or 2 more doses if in the government setup.
Yeah. So Arun, now the role of, this is a specific question, role of post-exposure prophylaxis of MMR vaccine.
So, this, like all other vaccines, what we have to see is how much is the incubation period and how much time does the vaccine take to work. So here, if you give it as early as possible, within 48 hours ideally, or maximum 72 hours, it does help. If you have been exposed to a child with measles, it does help. In cases of rubella and mumps, it doesn't really help. And the exact reason, we've had this discussion in lots of conferences, we've never been able to find out, but probably the effect of the vaccine comes much later. Although the incubation period is 7 to 10 days, the effect of the vaccine comes 15 days later. So in mumps and rubella doesn't help, but does help in protection against measles.
Yeah, so I think Arun has specified it. Dr. Praveen sir, 4 years old Tanay has received vaccination till 9 months of age. How many doses of MMR can be given to him? So unmute yourself.
We can give 2 more doses, one at 1.5 years and the second at 4.5 years.
Just so 15 months. 15 months we can give, sir, the second dose. And third dose would be 4 to 6 years anytime.
Right.
Arun, catch-up vaccination too. Arun,
yes,
there have 3 brands of MMR. You tell the audience at large, is there any superiority of one brand over the other? Can it be given at all the ages? And what is the preference of the brands?
Okay. So there are 3 brands available in the market. One is the standard Serum Institute, which we've all been using for ages, the Tresivac. Then there's another brand, Priorix, which is through GSK. And now, since last 2 years or 1.5 years, we have this Zyvac MMR that is made by Zydus Cadila. So there are slight differences, although the composition doesn't vary much. Like in the Priorix, which is by GSK, the strain used by for mumps is different. Instead of the Leningrad Zagreb strain, they use a version of the Leon strain. And whereas in the MMR used by Zydus, the mump strain is different. They use a Schwartz strain. So the differences are very less. Practically speaking, they're the same. The problem with Zyvac MMR is that the studies were done only for children between 15 to 18 months of age. So technically, if we have to go by strict criteria, you can't use the Zyvac MMR vaccine in children 9 months of age and 5 years of age also. And they can be used only 15 months to 18 months because the studies were done then. But otherwise, theoretically, they said that, the Tresivac, the Serum Institute MMR, the chances of mumps aseptic meningitis are slightly more. Till now, in 32 years, I've seen only one child having it. So it's a very theoretical risk, which the Priorix people claim that it does not happen with their strain, which is the instead of the Leningrad Zagreb strain, they use the other strain. I'm forgetting the name, but that doesn't cause. So I think that's a very theoretical difference. Otherwise, we've been using the Serum Institute vaccine for such a long time, and we've had no problem at all.
Yeah, Sagar, you are there online?
Price-wise, if you look at the Tresivac compared to Priorix is much more economical.
Yeah, so I think all the 3 experts have clarified the doubt about the measles containing vaccine, whether it is the MR or the MMR. Standalone measles is no more available in the market, and standalone rubella also is not available in the market. So the 2 brands which are available, MR, which is mainly manufactured by the government supply, and the MMR one, which is available for us pediatrician to use in our day-to-day practice.
See, the carry-on message will be give any, but give it.
Yeah, I think that's very clear. The next live vaccine which we are going to discuss is going to be the varicella vaccine. And Arun, what are the rates of seroconversion after varicella vaccine? It's another live vaccine which is given in combination with MMR. So what are the seroconversion?
So the combination vaccine of varicella and MMR is not available now, MMRV. We get only chickenpox separately. And the seroconversion would be to the tune of around 85% after 1 dose and to the tune of 97 to 99% after 2 doses. That is seroconversion. But like you've shown here, the efficacy is slightly different. If you have against mild disease, 70 to 90% in 1 dose, in second dose 98%. And the good point is that that is the main purpose of giving the vaccine. There is 100% protection after second dose against moderate to severe disease. So even if the child has chickenpox after 2 doses, as we've all seen, the disease is very mild. The lesions are less than 50. They're just macular in nature. They don't even form vesicle, maculopapular in nature. And they go off in 5 to 7 days without fever. So that is the good part of the vaccine.
Yeah, so initially when we started using chickenpox vaccine in our day-to-day practice, we were using single dose. And then I think we shifted it to the 2-dose schedule. And of course, we will have a discussion on the schedule when it's to be given. As Arun told, seroconversion is 86% vis-a-vis 99% for 2 doses. But the prevention or efficacy against moderate to severe doses goes in the tune to 100% if you use a 2-dose. So all of us in our practice use 2-dose schedule for a chickenpox vaccine. Dr. Praveen Mehta.
People, want to know whether to give it after 3 months, the second dose, or at 5 years of age.
Yeah, so I will take that question.
Okay.
We will take it ahead. Praveen Mehta, sir, this is one vaccine where the parents may come to you telling that the vaccine has been given, but he's got a breakthrough varicella. What do you understand by breakthrough varicella? Is it really worrisome? Is it really infective from a community perspective, and what are the strategies you can do to prevent it?
See, breakthrough varicella is defined as the varicella occurring after 42 days of giving the first dose of the chickenpox vaccine, that is varicella vaccine. And usually it is mild, and usually it takes around 2 to 5 years following the first dose. It happens. And there are no cases of varicella breakthrough reported in those children who have taken 2 dosage. As in the earlier slides, you have already shown that the breakthrough varicella is almost 100% protected by giving 2 dosage. And with the 1 dose, there are about 15% chance of child getting breakthrough varicella. The reason why the breakthrough varicella occurs is postulated for 2-3 reasons. Suppose the child was given the vaccine before 15 months. If child was given the vaccine with less than 1 month difference with the measles containing vaccine, and if the child was given at a later age, that is in adolescent, then the chances of breakthrough infections are much higher compared to the routine one. So following this experience, even IAP has recommended the 2 dosage of vaccination with varicella. Previously, it was recommended, the second dose was recommended at school going age, that is 4.5 years. But now the recent studies have already shown that you get the same result whether you give it at 4.5 years or 3 months after the first dose. So recent ACVIP recommendation says very clearly that give the second dose 3 months after the first dose.
Arun, do you want to add anything that why there has been a preponement of second dose of chickenpox for
Yeah.
4.5 years?
Just a little more detail that, when you give at 5 years, if the coverage is good, like in America, so there are no breakthrough cases. Like as I told you, 85% protection is there after the first dose and 99 after the 2 dose. So that means 15% children can still get varicella if you postpone the second dose from say 18 months to 5 years of age. So those 15% appears to be big. And because there is community transmission, because everybody is not vaccinated. In countries where America and all, where people are vaccinated, the cross transmission does not happen in the community. So by giving earlier, we are covering these 15% children also who may have had a primary failure. The only point is that if you give early, they have seen that the cell-mediated immunity is slightly less, but it is still worth giving after 3 months rather than waiting for 5 years of age.
So
And
I think that
the chances of herpes zosters are less.
Yeah, if you don't have chickenpox, the chances of herpes also become less. So it's not only a varicella vaccine, you can say it's an indirect long-term herpes zoster vaccine also.
So I think the take-home message to the audience at large, 2 doses. The second dose you can prepone from the school entry to around 3 months after the first dose. Probably the compliance is better, the coverage is better, and the cell-mediated immunity doesn't decrease. So your chances of breakthrough also are much on the lower side. Specific question to Arun. You have a 29 weeks preterm unit is born to a mother with active varicella disease since 2 days before delivery. Is this baby at high risk of getting disease, and how should I protect? I think as a pediatrician, we do get a call and the mother's having an active lesions. So just want to specify what should be our protocol to look at the term babies, the preterm babies, when does the rash come, what is the significance, and how do you really manage such cases?
So, this child is, it is said that if the mother gets the chickenpox 5 days before delivery or 2 days after delivery, then the child is at high risk. And this child, as the mother got the disease 2 days before delivery, the child is at high risk. So we have to give the child varicella zoster immunoglobulin, which is not available. So we'll give him the general immunoglobulin because all immunoglobulins will normally also have varicella zoster antibodies in it. And so that means that we have to protect the neonate. The child is at high risk of mortality because of varicella. So we have to give this varicella zoster immunoglobulin. So 5 days before, 2 days after delivery, any child, you have to give it. And then other than that, this is 29 weeks. If the child was less than 28 weeks, then we classify whether the mother has had disease or not, whether the mother has antibodies or not. If the mother has antibodies, then you can wait. Otherwise, if the mother doesn't have antibodies, you have to give the child varicella zoster immunoglobulin, even if there is no history of contact. If there is history of contact, but we don't know whether the mother has had the disease or not.
So I
So
think
it
it's
has
very
been
clear.
defined that the main reason why they are very high risk is that the transmission is transplacental, which is extremely high compared to airborne transmission that we see normally in school-going children.
So I think the message to the colleagues is very clear. If you come across a mother who has a varicella, which is 5 days before delivery or up to 2 days after, the chance of transplacental transfer is high. And if the neonate gets infected, the mortality is very high. And herpes encephalitis do occur with temporal lobe affection. And of course, as Arun rightly said, it depends upon whether it is 28 weeks of gestation or about 28 weeks, depending upon whether the maternal immunity is there or not there. And of course, pregnant woman without evidence of immunity. So 5 days before and 2 days after is a concern. So
Can I add one thing, sir?
Sure, Sagar.
Welcome back.
Yeah. Yeah. First of all, pardon me, because of some network issue, I'm facing lots of problem here. So what will happen if the mother is going to have varicella 5 days prior to the delivery? Still, she is going to transmit it to the neonate. So now there are many countries like European countries and Australian countries which have different guidelines. We say that from 5 days prior to 20 days prior to delivery, still the mother can transmit the varicella to the neonate, but they have a very large data. And what they have noticed that in these cases, the mortality in the neonate is 0%. But in this particular slot, that is 5 days prior to delivery and 2 days after the delivery, the mortality is 20%. Now, even the most of the data they themselves cannot or could not actually give a immunological reason why such a thing is there. But yes, such a thing is there, and that's why only we have considered this 5 days and 2 days slot. Now, one thing is sure: if the mother gets varicella 20 days prior to the delivery to 5 days prior to the delivery, the neonate will have a rash in the first, second, third, or the fourth day. But if the mother is going to have varicella 5 days prior to delivery and 2 days after the delivery, the child will land into rash from 5th day onward to 10th day, extendable to 12th day. The rash will be there. If a rash occurs, there is no point in giving immunoglobulin. We'll have to treat the child with acyclovir. So many times there is a confusion that the child is having a rash. Now should we give immunoglobulin? No. The child is now already infected. The rash is there. So now you have to treat the child with acyclovir and not with immunoglobulin. So immunoglobulin is basically for prophylaxis only.
Yeah. So I think both of
them. One reason why we can think about, I am not very sure, but 20 days prior to delivery, if the mother gets chickenpox, she might be also passing the antibodies to the child.
Yeah. So that's the reason. The antibodies are passed. So now there is no problem.
Yes.
So I think all the three experts, I think, remember that chickenpox 5 days prior and 2 days after delivery, transmission to neonates, you need to protect him. You have to give passive immunization with varicella zoster specific immunoglobulin, which is not available. In that case, we shift it to a broad spectrum immunoglobulin. And if that also is not there, you can use an acyclovir, which in a prescribed dose. Sagar.
Yes, sir.
Arya has developed varicella today. She has played with her neighbor Raghav, who is 2 months old, 5 days before for 10 to 15 minutes. Is Raghav at risk of getting varicella? And I think this is the problem which we encounter with so many parents coming to us saying that somebody in the school got it, somebody in the neighbor got it, somebody. So how you are going to look at giving varicella vaccine to a child who comes to your OPD?
So I'll answer this in two different ways. Number one is what exactly is a contact case. So any person who has a face-to-face contact with a varicella patient or anyone who dwells in the same room even for 1 hour with the infectious patient. And what exactly is the infectious patient?
1 to 2 days prior to the rash appearance till the lesions or crust form on the lesions. So this is an infectious patient. So even if any child faces any infected child face-to-face contact or lives in the same room for 1 hour, that will be called as a contact. Now, in this case, which you have asked, the contact was 5 days prior to the rash. So legally, it will not be considered as a contact. Number one. Number two. Now, let us say that this newborn 2 months old had been exposed to a case of chickenpox. He is not at any special risk or any risk of complications, and so it does not warrant any prophylaxis in the form of immunoglobulin or cyclovir. So, as what I was saying earlier, after 12th day in a neonate, let it be a 2 months baby, 3 months baby, an infant, a 1 year old baby. Even if the baby is exposed to any case of chickenpox, there is no need to give immunoglobulin to a normal immunocompetent child. No need for acyclovir also. Only and only if the child is immunocompromised or immunosuppressed, then and then only we give prophylaxis in the form of immunoglobulin. And if immunoglobulin is not available, we can give in the form of acyclovir.
Yeah, so suppose you come in contact with, suppose one of the schoolmate of a patient coming to in the OPD has got chickenpox, and mother says that I want to protect the child. So what are the duration in which you give the vaccine and you can counsel the mother accordingly?
So whatever data is available, if we give post-exposure prophylaxis within 3 days, the efficacy achieved is 90%. If the
Good.
post-exposure prophylaxis is given within 5 days, the efficacy is 70%. Now the question is, can I give after that? Yes, I can give after that, but we will have to do a one-to-one discussion with the mother that the vaccine might or might not work because the child might already be in the incubation period. So in that way, you can counsel and you can give vaccine as a part of post-exposure prophylaxis in a child.
Yeah, so I think Sagar has specifically told if you come across with any child in the OPD with a history of exposure, I think within 3 days of contact, it's around 90%. Within 5 days, around 60 to 70%. After that, you cannot say, but it will protect the child from the chickenpox in future. So I think that's the role of giving chickenpox vaccine. The next thing I want to ask Praveen Bhai, what are the brands of chickenpox vaccine which are available in the market? And is there anything superior over one brand over the other?
There are mainly 3 brands available. One is Veripaid by MSD, the other one is Verilrix by GSK, and the third one is Nexipox, which is a Chinese manufacturer but marketed by Nova Medicare. Now, by and large, all of them are derived from Oka strain. They are all live vaccine. They are all available in lyophilized form. Only difference is that there is a trahelose as a content in Nexipox brand, and which gives them little more storage period. Say that their shelf life is, if stored at 2 to 8 degrees, it is 3 years compared to other 2 vaccines which is 2 years. But if you look at the effectiveness data, it does not have the post-marketing surveillance like what Veriped and Verilrix are having. And those 2 vaccines have been tried millions and millions of dosage, and the post-marketing survey and the effectiveness was shown to be a proved vaccine compared to an Nexipox. And I don't think that containing trihelix makes a drastic difference in the efficacy.
It's only the shelf life which is more. Also, sir, it does not have gelatin and MSG, the monosodium gluconate. So if somebody is allergic to gelatin or MSG, they also can go for that vaccine. Otherwise, efficacy-wise, all of them are same. Good.
Yeah, Arun, any vaccination schedule for MMR chickenpox, because they both are live vaccines. So would like to tell the audience at large.
So the schedule is, because both are live vaccines, they can be given between 15 to 18 months, and they have to be given together. And if you don't give it together, that means on the same day, then you give a gap of at least 28 days, 4 weeks gap. And then the second dose of chickenpox is given after 3 months minimum. And the third dose of MMR is at 5 years. So 15 months is the time when both of them can be given together.
Yeah, so I think since both are live vaccines and basic principle of vaccinology, the live vaccine should be given at same go. If there is going to be a gap, then actually you should have a 4 weeks gap for a better uptake of the second vaccine which is there. I think that basic principle holds true for an MMR and chickenpox. So that finishes our queries on chickenpox. Sagar, if you get a breakthrough varicella infection after the dose of varicella, is it as infective as that of the chickenpox rash or chickenpox rash?
Yes. So basically, it is said, and according to some literature, if more than 50 lesions are there, it will be considered as important. But actually, there is no such scientific data from where this 50 number has come. So any rash, let it be a breakthrough varicella or varicella occurring in any child, will be an infective one.
The main thing is the infection is through the lesions which are occurring on the skin. And if that child happens to be in a family who has an immunocompromised person, then it is a matter of concern.
Okay.
So, I'll just add one thing. I had read somewhere, I cannot find it again. They say if the normal chickenpox is around 500 lesions per body, if you have had one dose of chickenpox vaccine and after that you get the disease, the breakthrough after one dose, the child will have somewhere between 50 to 100 lesions. And if the child has chickenpox after 2 doses breakthrough, then the lesions are around 20 to 30. So approximately they must have done a study and counted. And the chickenpox happening after 2 doses, as I said, was only maculopapular, no fever, and lasts only for 5-7 days.
Okay. So I think this covers the second vaccine, that's the varicella. Third, I think, which is the new vaccine on the horizon, which Sagar, my
Yes, sir.
uncle is 56 years old and is a known diabetic. Which vaccine I would recommend to him?
How can your uncle be 56? He will be your cousin.
Yeah, fair.
So first of all, let me start by saying that diabetes, we don't consider diabetes as an immunocompromised patient. But yes, we do agree that diabetic patient lands up into many complications, and therefore diabetes always comes as a priority group. Now consider this, that the age is above 50 and there is another patient above 65. So those who are above 65, a Tdap dose, a flu dose, a pneumococcal dose, and a herpes zoster are a must. But in those who are above 50, but especially like this patient who is diabetes and a priority group, yes, you have to offer him a Tdap dose, a flu vaccine dose, a pneumococcal dose, and a herpes zoster dose also. So these 4 vaccines should be offered, especially there is a comorbidity in this 56-year-old uncle.
So now I think the new vaccine which is on the horizon is the herpes zoster, though it's not a pediatric domain vaccine. Arun, little bit indication on herpes zoster. What are the types of vaccine available? What is the efficacy? And should we recommend it? And should all above 50 years take it?
So, we have started giving the herpes zoster vaccine, even if they are pediatricians, are given more than 20 doses now. And parents, they bring their parents, that means grandparents do come and ask. And because of the cost, half of them don't come back. But still, we have started giving. So the indication, although the vaccine is licensed for people above 50 years of age, I generally tell them to come once they're 60, 65. So I tell parents that you wait, get your grandparents of the child, that means your parents, to come. So although it can be given after 50, we should definitely give it to people who are above 60, 65, when we know that the cell-mediated immunity now will gradually go down. And if we show statistics, the chances of having herpes zoster at 50 years of age, it's only around 20%. And by 65, it becomes 33, 35%. And once the person reaches 80 years of age, it reaches almost 50%. So there's a 50% chance of a person above 80 years of age to have herpes zoster. So we must vaccinate older and older age groups definitely first, and then the younger ones. There is just now only one type of vaccine available. Earlier, there was another one, the MSD vaccine, which was the Zostavac, which was a live vaccine. And usually we say live vaccines are better than kill vaccine, but that was one vaccine which wasn't better. Maybe it was single dose, maybe the number of virus particles were less. After giving Zostavac, which was given as a single dose, the antibody titers against chickenpox rose by 2.1 to 2.3 times in different studies as compared to placebo. And it was given only a single dose. And the efficacy, if we see against herpes zoster, was 65%. But the most important thing is the herpes, the post-herpetic neuralgia. That is why we give the vaccine, not to protect against herpes so much as to protect against post-herpetic neuralgia. There, the efficacy was 61% for, say, 60 to 70 years of age. 70 to 80, it was 64, 65, and above 80, it was only 34. And like I told you, the chances of chickenpox are more, of herpes zoster are more after 80 years of age. And out of these herpes zoster people, 20% will develop post-herpetic neuralgia, and the efficacy against post-herpetic neuralgia above 80 years was only 20%. So it wasn't really a very good vaccine in terms of cost effectiveness. It did cost 7,500 rupees, but gradually it has been withdrawn from here. And America it's still available, but probably nobody uses it just now because we now have a better vaccine, which is the Shingrix. This is made by GSK. The cost is 11,000 rupees. It's given in 2 doses, 1 dose now, 1 dose after 2 to 6 months. And the efficacy here, the titers, like there, it rose by 2.1 times to 2.3 times. Here, the titers rise by 6.5 to 7.1 times more as compared to placebo. And the efficacy is close to 93, 95%. The protection against post-herpetic neuralgia also is 90% plus, even for people above 80 years of age. So out of the two, since the other one is not available, if there's a match and one person withdraws from the match, there is no match now. But if you have a choice out of the two, definitely go in for this killed inactivated vaccine, which is the Shingrix, which is given in 2 doses. And efficacy, I told you, dosage schedule also, I've told you. That was a single dose, this is in 2 doses.
Sagar, you want to add?
Other
Yeah,
thing
I
is,
add that. Yeah, Praveen sir, please go ahead.
the other thing is it has a 10 years follow-up, which has shown a good efficacy even for the age above 80 years for post-herpetic neuralgia. For post-herpetic neuralgia, it has shown efficacy of more than 70% even after 10 years of follow-up, even for the age above 80 years. So it's a fantastic improvement over the existing and other things. Zostavax is now completely withdrawn from the Indian market.
So one
Sagar,
thing
you
which I
want
would like to add, the Zostavax was a live vaccine, and most of the elderly have some or the other form of comorbidities, immunosuppression, malignancies, and so this Zostavax was contraindicated in most of those individuals because of this comorbidities and immunosuppression. So here there is a lot of benefit with Shingrix, which is a recombinant GP protein ELISA vaccine, which is a killed vaccine. And Arun Wadhwa sir has already said, Zostavax, the overall efficacy was only 49%, and efficacy at the 8th year was only 31%. In as far as the Shingrix is concerned, the overall efficacy is 97%. And even if we give above 80 years age, still the efficacy is 91%. So very, very much advantageous vaccine. The only thing which Arun Wadhwa sir was saying about the age at which Dr. Arun Wadhwa sir is recommending it, let me tell you, in the Western world, the coverage of chickenpox vaccine is very high, up to the tune of 90 to 100%. The transmission is very low, and therefore the transmission to the elderly is low. Therefore, the natural reaching to the adults and elderly is also very low. So now what has happened that the herpes zoster, which used to occur at an older age, let us say 70, 80, the age has come down now, and now they have started getting herpes zoster in and around 40, 50 years or even less than that also. And that is the reason why Shingrix, which is allowed above 50 years, holds an advantage here. Now in India, there is no such large-scale vaccination for varicella. So here you might be experiencing that the herpes zoster is more in around 70 or around 80, but in Western world it is opposite. The age incidence has come down. So there they require this vaccine above 50 only. So that is the major difference.
No, but why I don't tell them at 50 years? Suppose, the vaccine efficacy, they say, like Dr. Praveen said, is 10 years. And even if you do mathematical modeling, they say it may last up to 20 years. And so this patients who have taken at 50, 55 years, the efficacy will last till they are 65, 70. And the chances of getting herpes are much more after that. So unless they do more studies, they say that after 10 years, 15 years, give one more booster. We're not sure whether this vaccine will, given at 50 years of age, will last till the person is 85, 90, or even 90 plus.
I agree, but depriving the patient of vaccine because we don't have data is like letting the patient suffer from the disease. So we cannot basically say like that I will wait for more 10 to 15 years because the efficacy data is more. I think it is better to offer that vaccine, and we will get more efficacy data as time passes. So at present, also the follow-up says that 15-year efficacy of around 90% is there. So might be after few years we'll understand the efficacy might be lifelong also. So presently depriving the vaccine on that point, I humbly beg to differ from that view.
Also, if you give it around between 50 to 60 years of age, the efficacy is highest, means almost like 100% efficacy, more than 98%.
Yeah, but how long will it last? That's the question, sir.
If you take the average life expectancy of Indian population, it is 72 years only.
No,
So
but the people who are taking this vaccine, they live till 90 years.
I think this is the new vaccine, but I think the message which is given by all the three panelists is now we have a vaccine which is given above the age of 50 years. It's for prevention of herpes zoster. Recommendation is above 50 years. The single brand available and licensed in India is Shingrix. 2-dose schedule, one now and the second after 2 to 6 months. It is for prevention of herpes zoster, but more important than that, as Arun told, it is the post-herpetic neuralgia morbidity which comes down. The only limiting factor today, as on our population goes, is the cost. I'm sure this vaccine has its own niche in the practice for elderly population to come. So that finishes the herpes zoster. So for all the audience, we have looked at 3 live vaccines: the measles containing vaccine in a form of MR or MMR, the other live vaccine, which is from the herpes, is the varicella vaccine, which is another live vaccine, and the schedule. And the last, which has hit on the shelf in the last year or so, has been the herpes zoster vaccine by the GSK as Shingrix, which is available to be used in the population above 50 years of age. I think that's all from my side. If there are any questions from the audience.
I think chat box has a few questions.
Now, herpes zoster, we are not worried about the skin lesions as such. But in immunosuppressed and elderly, there are always chances of pneumonias, chances of transient ischemic attacks, chances of strokes, chances of encephalitis, chances of ocular involvement, blepharitis, blindness, chances of hearing loss.
Complications of herpes, basically. Yeah.
So basically, most of the elderly, as I said, are having some or the other comorbidities, and they can land up in this complication. And that is why this herpes zoster vaccine is more important in elderly. Now, specifically, Shingrix has been studied in HSCT, in renal transplant, in HIV, in immunosuppression, those who are receiving steroids, and they have found that the efficacy in this immunosuppressed population was also above 90%. And there lies the importance of giving Shingrix in all these patients.
There is one question which is asked by the audience, which Arun can take it. If the child gets infected with chickenpox before the age group of 1 year, will he be protected lifelong, or should we give him vaccine?
No vaccine required. He's protected. But only thing is, it has to be a diagnosed case by a physician, not the mother's diagnosis or the grandmother's diagnosis.
Right. So even if a neonate, an infant, anyone gets the lesions, earlier in olden days, we used to say that if a neonate or an infant gets the disease, the immunity might not be robust, but that is now an old concept. Now it is said that even if the infant or a child younger than 1 year also gets the disease, the immunity will be optimal. That is the recent update.
I think that's all from the questions which are there on the chat box.
Somebody wanted to know about needle-free injection. I saw that question initially. What about needle-free vaccination?
Arun sir, you only take it.
I only take it. Okay. I've been using this needle-free injector since last almost 5-6 months now. And you asked me practically, since it's not a sponsored talk by the needle-free injector, it's not something which is really great. It takes a little longer time to fill up the syringe. There's always a little chance of spilling, and it is painful. So it's not that it's painless. The only point where I use it is, those teenagers who are afraid of the needle, who see the needle and start fainting kind of attack. Or there are some teenagers who were not coming to take the 10-year TDAP because they said that I'm too afraid of the injection, I'll not take. So parents obviously can't bring them physically and come. So I've used in these children. And since they don't see the needle, they take it. After that, it hurts. But after that, the deed is done by then.
Dr. Wadhwa sir, is there any study about the uptake of the vaccine?
So
Is
they have been,
bioavailability is proper with the non-injectable form?
yes. So what they have shown is they did come up with 2-3 studies, and all of them showed that the antibodies level were the same, comparable. But again, they were very small studies. So, and actually, if the vaccine goes inside the muscle, in whatever way it goes, it should produce antibodies, isn't it?
No, but whether with that device the vaccine is able to be delivered inside the body, are we
No,
sure?
as long as it is not coming outside the body, it's inside.
Okay. I think that's it. We are on time, exactly an hour. It's 10:30. And I think 9:30 we started, and I think 10:30 we are done with the session.
Good
If
timing.
there are no questions, we would close the discussion. I must thank Arun on a short notice.
Thank you for calling me.
Praveen Bhai from Mumbai, and of course, Dr. Kulkarni from Aurangabad. Sorry for late communication for the questions, but the topic was simple and it's for day-to-day practice. And an expert like you, I didn't find anything would really become an issue. Thank you. Thanks a lot. And good night.
Thank you.
And
Thank
happy
you. Thank you
Diwali
very
in advance to all of you.
Thank you.
Thank you, Dr. Lalwani, for moderating it excellently.
Thank you, Lalwani
Thanks
sir.
a lot.
Thank you.